and it's 12 o'clock. And I know, as always, Rochelle has so much to cover, and it's all very valuable, and also give us some time for questions and for clarification. So we're really excited to have everyone today. Like I mentioned earlier, please in the chat indicate your name and the organization that you're with, especially if you want to continue education. In addition, please feel free. If you hover over your picture, you'll see the 3 dots, and you can click on that to change your name. We really are excited today to have Rochelle and to be talking about emerging telehealth legislation. Did also want to bring up that we're going to be sending out a survey to everyone who has registered and attended any of these so that we can get your feedback on what to cover next through these. We think that they've been very valuable. I hope you'll agree. But we're really ready to kind of see what else we should cover, what other areas are important as we plan our sessions in October and going forward. So hope you'll respond to that survey when we send it out in a couple weeks, I believe, Christy, and we can get more feedback on what's going to be beneficial and useful, whether it's covering another topic that we've covered in more depth, or revisiting a topic, or something new that we haven't addressed yet. We really hope you'll help us as we begin to think about what else to cover in this series. So with that, I'll hand it off to Rochelle. I know she's got a lot to cover. And thanks as always for being here and for your excellent content for the group.
Absolutely. All right. Thanks, Robert. Well, I'm just going to jump in. If you all have been on previous sessions with us, you know that I start to get excited. I start to talk a lot and tend to run right up against the 1 hour mark. So I'll go ahead and jump in with today's content so that I do try to leave time for questions for you all. So our topic today, we've covered in some of the previous sessions some proposed rules that are coming out with relation to telehealth and what I kind of refer to as quasi-telehealth services, things that are not your typical face-to-face services, but also that aren't telehealth the way that term is defined under the Medicare payment rules and requirements. So things like care management, chronic care management, transitional care management, remote patient monitoring that we've done a little bit deeper dive into in previous sessions. And we've talked about some of those proposed rules specific to what may be coming up next year in terms of payment rules for Medicare. But what I wanted to do this afternoon is to do an overview of some things that are happening at the state and federal levels, some bills that are proposed, so that we can kind of get a glimpse into what may be a more permanent changes to telehealth rules and requirements on the horizon. So what we're talking about today, these are largely proposed rules. Okay, so keep that in mind that these are not things that have been finalized. These are not rules for the most part that are going into effect, but it gives us a glimpse into what I think we can reasonably foresee happening with our telehealth rules in the coming months, in the foreseeable future. So in our previous sessions, we talked about the proposed Medicare fee schedule for 2022. So I won't go into a ton of depth on that. I do encourage you to go watch that session. We had a recorded session and then kind of a workshop Q&A to go through some specific questions. So hopefully between those materials, that will give you a pretty good feel for what's being proposed. I suspect let's see, this is September. Usually it's about the second, third week of October. It's probably going to be a little bit later, maybe even into the first week of November, that we'll see the final rule come out, and we'll certainly share updates at that time with respect to telehealth and kind of the quasi-telehealth non-face-to-face categories of services. But some of the major provisions that were proposed in the Medicare 2022 fee schedule actually extend beyond the year 2022, in that those services that are currently on the list of Medicare covered telehealth services as this new category 3, which are those that have been added on a temporary basis during the public health emergency. If they're designated as category 3, those prior to the proposed rule would be covered through the end of the calendar year when the public health emergency ends. So at least this December 31st, It's looking like we would probably go into at least January of 2022 with respect to the federal public health emergency, which means those temporary telehealth services would continue to be covered through December 31st, 2022. But in this proposed rule, Medicare, if finalized, would extend that even further, that regardless of when the public health emergency ends, knock on wood, hopefully sometime in the foreseeable future, that those Category 3 temporary telehealth services will continue to be available and covered and payable by Medicare through December 31st, 2023. Now, what that means for you all, if you're delivering any of those services that previously were not covered as telehealth, currently are during the public health emergency, is that there is a chance that they go away December 31st, 2023, if that extension gets finalized. So to make those covered on a permanent basis, a couple of things need to happen. Medicare needs more data to show the efficacy of those services as permanent telehealth services, that they're safe, they're effective when delivered via telehealth, any frequency restrictions, and there are deadlines each year to submit requests for temporary services like these Category 3 services or proposed services to add to the telehealth list. I believe that's in February of each year, the deadline to have them considered to be covered for the following calendar year. So if you've got data, if you're collecting information on usage, on improved access, on parity in access, quality of care, reduced admissions, reduced higher acuity events with patients, all of those things are great data to include in your request. And I strongly encourage you to request that these services be added to the permanent telehealth list if you're providing them. The reason I'm pushing for that so much is that this year in the proposed rule, there were a few services that Medicare looked at adding on a permanent basis, but said that they couldn't consider a number of requests because the requests were not received on time and that they didn't have any requests from Category 3 that they could include on a permanent basis. So strangely enough, there's not a lot of requests being submitted to make these permanent, and maybe that's because providers knew that they at least had some wiggle room through the end of the year when the public health emergency ends. But there's a chance that coverage could go away entirely if they're not made permanent. I want to talk about some of the proposals for mental behavioral telehealth services being potentially expanded next year as well. So right now, even outside of the public health emergency, through the Support Act, there is some expanded coverage for telehealth services to individuals who are being evaluated and treated for substance use disorder or mental or behavioral conditions co-occurring with substance use disorder. So that's covered as a telehealth service with kind of two caveats. The originating site requirements are waived, not waived, let me say that a different way. Home is added as an eligible originating site for those services. That is typically not an eligible originating site outside of the public health emergency. And then the second flexibility on a permanent basis for these substance use disorder telehealth services or mental health conditions co-occurring with substance use disorder are the geographic restrictions in a rural health, a provider shortage area that are waived for these as well. For 2022, there's a proposal under the Consolidated Appropriations Act that would expand telehealth coverage not just to mental and behavioral health conditions that co-occur with substance use disorder. That is covered right now. But the Consolidated Appropriations Act, a statute, a permanent rule, would make that available to other mental and behavioral health conditions. So we have that statute, and then in this proposed rule, the parameters around covering that for payment are being proposed and introduced. And there are a couple of provisions in those proposals that are a little bit tricky. one of the requirements prior to a mental or behavioral telehealth service being provided, and again, if this were finalized, is that there would have to be a face-to-face non-telehealth service within 6 months. That is a requirement. Currently, I don't see changing when the final rule comes out because it originates from the statute that was passed by Congress. But let me put a little asterisk there because we're going to look at some proposed legislation that may affect that requirement. So we have a face-to-face non-telehealth service within 6 months of a mental or behavioral telehealth visit. Then the mental or behavioral telehealth visit can be for any mental behavioral telehealth diagnosis, okay? And it does not have to be co-occurring with substance use disorder. If it is, that's already covered under the Support Act, even outside of the public health emergency. Otherwise, if it's not co-occurring with substance use disorder, this Consolidated Appropriations Act also makes the home an eligible originating site for these mental behavioral telehealth visits and waives the geographic restriction for those visits. Under the proposed rule, these could also be provided as audio-only phone visits when certain requirements are met. So if the patient doesn't have access to audio-visual, doesn't want to use the visual component, or cannot for some reason, then they could be delivered via audio-only services. So there's a lot of caveats around that, and I'd encourage you to go back to our 2 sessions on the proposed physician fee schedule to really dig into those requirements. The other piece of this that's causing a lot of controversy that I could see potentially changing in the final rule is to deliver mental behavioral telehealth services where the originating site could be the patient's home and there are no geographic restrictions. And to use those 2 flexibilities, Medicare would also require in-person, face-to-face, non-telehealth services every 6 months, or said another way, within the previous 6 months prior to the telehealth visit. One thing I wanted to clear up that from the previous 2 sessions is that if all other normal telehealth requirements are met, meaning there is an eligible originating site like a provider's office or a hospital, the patient's in an eligible geographic area like a rural area or a healthcare provider shortage area, those 6-month in-person visits and every 6-month requirements do not apply. Those additional restrictions are only if we're taking advantage of the flexibility to deliver mental behavioral telehealth service to a patient who is at home and or outside of an eligible geographic area. In other words, it would not be covered as a telehealth service, but for those elements. So I did want to clarify that. I think the every 6-month requirement is something that could be changed in the final rule. So we'll currently keep an eye out for that when the final rule comes out and share an update with everyone once we figure out what the final rules are. So moving beyond what's proposed just for payment terms for Medicare for 2022 and potentially beyond, I wanted to talk about some of the bills that have been proposed to Congress at a federal level that take a look at those very restrictive requirements for telehealth services outside of the public health emergency, but really revisiting all of the restrictions on originating site, eligible distant site practitioners, geographic areas, the type of technology we use, and so on and so forth, and really visiting whether those requirements still need to be in place and considering making changes on a permanent basis, even outside the public health emergency, to our typical telehealth rules. So I want to go through some of these bills that, again, have not been finalized, but this gives you an idea of where Congress is heading, and we're going to see some common themes among these bills that I think gives us a glimpse into what we can probably expect sometime in the next year or 2 for permanent telehealth changes. And Christy, when we post these slides, you all can hover over the title of these acts, and that will take you to the text of the bill if you want to take a look and read, if that's the kind of thing you do in your spare time like I do. For your enjoyment, there are the text of each of these that you can access and dig further, and certainly let me know if you have any questions. So one of these proposed bills is called the Connect for Health Act of 2019. So the 2019 means this is a little bit older, which kind of gives me a glimpse into the likelihood of this moving forward as a final piece of legislation that gets enacted is maybe not as high as some of the others. But what this bill, I should say, proposed to do is give Health and Human Services the authority to waive telehealth requirements that so long as they don't deny or limit coverage, and any waiver of those telehealth requirements could be expected to reduce spending without compromising quality. So it's kind of an interesting approach in that we've got in the Social Security Act that was passed by Congress all of those restrictive requirements, and this would allow the agency of Health and Human Services to waive those requirements, like the mental behavioral telehealth services, allowing those to be delivered audio only in certain circumstances, and gives HHS that flexibility to do it so long as these certain requirements are met. It would waive all of the geographic restrictions, so rural areas, healthcare provider shortage areas, for any mental health service, whether or not co-occurring with substance use disorder. This bill would add the home as an eligible originating site for mental telehealth services, but not necessarily all telehealth services. It would add RHCs and FQHCs on a permanent basis as eligible originating sites, regardless of their geographic area. It would also make them eligible distant site providers, and would allow the hospice recertification that right now under Medicare rule has to be an in-person face-to-face outside of the public health emergency that has some waivers for that, and would allow that face-to-face visit to be provided via telehealth. So that kind of gives us a glimpse into some of the aspects of the stringent Medicare telehealth rules that Congress is looking at changing. So then, this has a link too, if you want to look at the text, there is the Telemental Health Expansion Act. Its most recent activity is that it was discharged by the Ways and Means Committee. So that kind of hints to me that it's probably not something that will be enacted on a permanent basis. But this would have expanded the provisions of the Support Act that allows expanded telehealth coverage for substance use disorder and mental health conditions co-occurring with substance use disorder to, quote, certain mental health services. This, I think, was largely replaced by the Consolidated Appropriations Act that essentially did the same thing. And that's what we see in the proposed rule for next year. So then there is the Telemental Healthcare Access Act. Looks very similar, would do some slightly different things. So this is a newer one. This was just introduced in the Senate in June of this year. It's had some activity. It's been read twice. It's been referred to the Committee on Finance. This act would remove, so remember when I was talking about the requirement under the Consolidated Appropriations Act that if we are going to deliver mental behavioral telehealth services, utilizing this flexibility to have home as an eligible originating site and non-rural geographic areas, then we must have an in-person face-to-face visit within 6 months of the first telehealth visit, and periodic intervals afterwards, which Health and Human Services has proposed to be 6 months prior to any subsequent visit. And that initiating in-person face-to-face visit before any mental behavioral telehealth services could be provided would be removed if this Telemental Healthcare Access Act goes into effect. Okay, so essentially you could start having telehealth services for mental and behavioral health. You could take advantage of the flexibility to do those to a patient, provide those to a patient who is at home and in outside of a rural area without needing that face-to-face visit in the preceding 6 months. This one I think has a decent chance of being enacted so far as we get appropriate support from behavioral health providers explaining the efficacy of providing those without needing that preceding 6-month visit. I think it's really interesting that that requirement was even put into place, because the counterpart for substance use disorders with co-occurring mental health conditions, and I'm not a clinician, but that suggests to me almost a more acute or complicated clinical scenario, does not have that face-to-face in-person requirement prior to those mental behavioral telehealth services. So that's one thing that's on the horizon that I think has a decent chance of maybe being enacted, and that would eliminate some kind of technical requirements that would otherwise go into effect. What I don't know is in the fee schedule proposed rule for 2022, they're operating under the assumption of the existing Consolidated Appropriations Act requirement for that face-to-face visit. So if the physician fee schedule rule gets finalized before, fingers crossed, the Telemental Healthcare Access Act gets finalized, we may have a period of time where that face-to-face visit is required for Medicare before there's like a correction notice or clarification from Medicare that they will abide by this act that takes that requirement away. The Fair Care Act of 2020 is another one that has been proposed and introduced to Congress. This is another one that has been discharged, so this particular act doesn't appear to be gaining momentum to get finalized, but I think the provisions within it are interesting to see how they are also finding their way into other bills that are being introduced. So this one would, the nomenclature, the Fair Care, is really focused on the distant site professionals who are eligible to render telehealth, rather than more of the originating site requirements that some of the other bills have focused on. So this would have added respiratory therapists, PT, occupational therapy, speech language pathology as eligible distant site practitioners. Outside of the public health emergency, those practitioners are not eligible to render telehealth services during the public health emergency. There are waivers that do allow them to render certain telehealth services, but that would go away once the public health emergency ends. So it would expand the services that are eligible for telehealth to include those respiratory therapy and the other therapy disciplines services, on the Medicare telehealth list of CPT codes, and also make them eligible distant site practitioners. This would also, in the remote patient monitoring codes that are currently available, currently covered by Medicare, it would do some things to the requirements for those codes where it would add that as a covered service for chronic conditions, where right now I put an asterisk by that because during the public health emergency, that is allowed for both acute and chronic conditions. So COVID, for example, if we want to monitor patients' respiratory status, pulse oximetry, those types of things at home, outside of a facility setting, we can currently do that, where typically remote patient monitoring are designed for the monitoring of chronic care conditions. One thing that I anticipate cause some problems with this particular service, or excuse me, this particular bill, is that it would describe remote patient monitoring, or define that on a statutory basis, as services where there's an auto transmission of data. That's what we already have with these codes. It includes vital signs. That's already part of these codes. or activities of daily living. And I think that is a problematic piece because the codes for remote patient monitoring are physiologic data only, where ADLs are more subjective inputs of ability to perform activities of daily living. However, we already have in the Medicare proposed rule for next year a set of codes very similar to remote patient monitoring, but they're called remote therapeutic monitoring. And they would fall under the medicine section of the code book. So they are not evaluation and management services. They would not be limited to being reported by the types of professionals who can bill E&M as part of their scope of practice. And RTM codes are designed to collect more subjective data like activities of daily living. So we're kind of already addressing that expanded definition through the proposed Medicare fee schedule. This act would have created some of the same waivers as the Connect Act for healthcare services, geographic restrictions, RHCs, FQHCs, and hospice recertifications via telehealth. So that tells me now we're starting to see some commonalities among these bills, and RHCs, FQHCs, geographic restrictions, and originating sites are starting to be some common threads there. The Telehealth Modernization Act is another relatively recent one. It was introduced in the Senate in February of this year. And some themes that we're seeing again, it would remove the originating site restrictions for all telehealth services, not just mental or behavioral telehealth services. And it would give the authority to Health and Human Services to expand the types of distant site practitioners eligible to provide and deliver telehealth services, but it doesn't mandate any professionals. So if I go back one slide, the Fair Care would mandate and make on a permanent basis all the therapy disciplines that define them as eligible distant site practitioners. Whereas this act just says Medicare Health and Human Services, you can decide when you're deciding services that can be added as telehealth services, who can provide them, but we're not going to dictate any particular professionals that need to be added to that list. We'll leave it to you. The other thing that this act would do, and I'm viewing this in light of the proposed Medicare fee schedule rule that, remember, takes this temporary Category 3 bucket of telehealth services that was created during the public health emergency and would extend coverage of those through December 31st, 2023 if finalized. Okay, that's on a kind of a regulatory basis. This act, if passed, would make those permanent telehealth services even after December 31st of 2023. So it would define by statute that all of those telehealth services would remain covered on the list on a permanent basis. So then we have protecting access to post-COVID-19 Telehealth Act of 2021. Say that 3 times fast. This one's also was introduced earlier this year, and it would make permanent changes to the Social Security Act for telehealth services like many of the others would, taking away the geographic restriction, meaning the rural healthcare area, the healthcare provider shortage area, services outside a metropolitan statistical area. And that would permanently be removed for all telehealth services. It would add the home as an eligible originating site for telehealth services, and it would permanently make FQHCs and RHCs eligible distance sites. That's a flexibility that they currently have during the public health emergency that was not available to RHCs and FQHCs prior to the public health emergency. So this one is interesting because I see a lot of those common threads about home as the eligible originating site, geographic areas, RHCs and FQHCs, and that tells me that those are really hot topic areas that I see a good chance of being finalized, whichever act Congress decides to take and run with and enact, that's probably on the horizon for us. The other thing I think is interesting when we're looking at these federal bills that have the potential of being passed is if we go back to the mental behavioral telehealth that is expanded under the Consolidated Appropriations Act and available to patients in their home outside of rural geographic areas, is that if these requirements are passed, that home is an eligible originating site for everything, and we no longer have to be in a rural geographic area outside the public health emergency, then those mental behavioral telehealth services become covered just like every other telehealth service. They're no longer relying on the Consolidated Appropriations Act to be covered, which would then mean we no longer have to have a face-to-face non-telehealth visit in the preceding the initial telehealth visit, and we would not have to have the face-to-face visit every 6 months. So we may do away with those requirements through the enactment of one of these pieces of legislation that would make those telehealth services, mental behavioral telehealth, the same as everything else in terms of originating site and geographic sites. No, I'll pause there. Christy, do we have any, I haven't checked the chat to see if we have any questions.
I don't see any so far.
Okay,
So feel free to chime in with questions or type them in the chat.
Okay, all right. Wanted to make sure I took a breath there, but I'll keep going in case, but please do submit questions if you have them. Protecting rural telehealth access. You're going to see some common threads here. The geographic restriction, it would take that out. It would add home as an eligible originating site for all telehealth services, RHCs, FQHCs as distance sites. The interesting provision about this act is that it would also expand coverage to allow asynchronous store and forward communications to be covered as telehealth. And that one's a little bit unique about this act. But we certainly see that common thread of the other topics that have been in many of the other acts. Permanency for audio only telehealth. This is a pretty new one. This was just introduced in May of this year. And it would also address that audio visual real-time two-way telecommunication piece of the telehealth requirements under the Social Security Act, and it would allow the use of audio only equipment to furnish audio only evaluation and management services, mental and behavioral health services, and substance use disorder services on a permanent basis. And then would give Health and Human Services the authority to make other telehealth services available as audio only as they see fit as well. And that would go through the rulemaking process, probably through the Medicare Physician Fee Schedule each year. There are a few others at the federal level that I just wanted to highlight. The Connected Moms Act would address barriers to allow remote physiologic monitoring devices under state Medicaid programs and make that more available to pregnant women, postpartum women for their follow-up and continuity of care. Behavioral Health Services Act would allow mental health professionals in the Medicare and Medicaid programs to provide more telehealth services and would create some payment parity for those mental behavioral telehealth visits, parity with an in-person face-to-face service. All right, so I'm going to shift gears a little bit and talk about some things that are happening at the state levels. Now, the Kansas Telemedicine Act, there's not really anything that's changed very recently on this, but I wanted to address a couple of kind of nuances of it. This went into effect, well, I should say it was set to go into effect January 1st of 2019. And some of the provisions of the Kansas Telemedicine Act allows telemedicine to be used to create, to establish a provider-patient relationship. It created coverage parity for telehealth services, but not payment parity. So a service that is provided in face-to-face must be also covered and paid for whenever it's delivered as a telemedicine service to the extent that that's possible, but it doesn't mandate that payers pay for the telehealth service at the same level as the face-to-face visit. So the Telemedicine Act was challenged in 2018, and right at the 11th hour, December 31st, 2018, right before this was set to go into effect, there was a judge decision on the Telemedicine Act that kind of created some questions on it going into effect. I think this was interesting, and Robert, you and I kind of exchanged some messages about this a few months ago, that initially the way the judge's order was characterized is that it struck down the entire Kansas Telemedicine Act. The issue with the Kansas Telemedicine Act is that there was a provision in there that no abortion services could be delivered via telehealth. So that whether that's a prescription or any other abortion services. And then there's a separate provision saying that the act is non-severable, meaning it's either all or nothing. And so if there was a challenge, for example, to the abortion provisions of the Kansas Telemedicine Act, and if a judge struck down that provision as unenforceable or a violation of law, then the entire Telemedicine Act goes away. Initially, when the judge struck down that order, if you were to go search for that and kind of read the news publications, it looks like the Telemedicine Act was struck down and was gone. Actually, what the judge's order said was that it wasn't ripe for review yet. There wasn't standing because there were other court cases that were pending some review and discussion of that. So these statutes are still on the books. They've still been followed by the Medicaid program and their policy bulletins that went into effect, effectuating the provisions of the Kansas Telemedicine Act are still there. And we haven't seen any activity since then. Under Kansas Medicaid, so a couple of things that are important here in the state of Kansas, our state emergency declaration status is no longer in effect. And that happened, I should have put the date on here, I think it was back in May, if I remember correctly, around May 4th or May 10th. So that the emergency declaration going away has some impact on telehealth provisions that were made available as temporary flexibilities or executive orders or agency policies because of the state emergency status. There is, and this is an active link when you get the slides that you can click on, under the Kansas Board of Healing Arts, there was a temporary licensure process to get providers that have an active license in other states a license to provide telehealth to individuals in the state of Kansas. That kind of expedited licensure process was made permanent by the Kansas Board of Healing Arts, and there's an application process that providers can go through. It's not a full active license to practice medicine. It's kind of limited in scope to telemedicine services. The Medicaid flexibilities that went into effect as a result of the state emergency declaration are still in effect right now, and most of those policy bulletins have a little provision that says until rescinded. And when I checked on this earlier this week, I haven't seen any bulletins or notices that those policies are being withdrawn or rolled back at this time. So currently, any of the expanded services and flexibilities under the Medicaid program that were made available as part of the COVID emergency are still available at this time. There is one going into effect that's new that will be available October 1st of 21 if you are a CMHC in Kansas, about the use of mobile crisis intervention and a new code for those services. And there's a link to that policy here if that's something you provide to take a look at. In Missouri, the emergency declaration was terminated effective, I keep losing track of my months. It's already September, August 27th. So gosh, a week or so ago. But the interesting, so it was the COVID emergency declaration at the state level that was terminated. But the governor then has a new emergency for staff shortages. And so the COVID emergency at the state level is gone. There's a new emergency due to staff shortages, and that emergency order declaration incorporates the executive orders from the prior emergency, such as those related to telehealth, into the new staffing shortage emergency declaration. So in kind of a weird roundabout way, those telehealth flexibilities through executive orders in Missouri are still in effect. So this right now is in effect until December 31st, unless it's renewed or unless it's rescinded or expires at that time. And part of the order says all waivers that were previously authorized, and we've got some numbers here, are still currently in effect. So some of those particular orders that are relevant to the provision of telehealth, I just kind of renewed that quote here. Executive Order 2004, that was the original COVID emergency order in the state of Missouri. It gave agencies the authorities to create waivers due to the COVID public health emergency. And then all of those subsequent orders that are listed there were an extension of that. So if I go back one slide, it's just incorporated by reference, all of those flexibilities, all of those executive orders, but it's just changed the name and kind of the approach to the state emergency status. In Oklahoma, what am I trying to say? The emergency status was also rescinded. My gosh, I'm tripping over my words here. Oklahoma actually had a statute, payment parity, passed in May of this year. So this is set to go into effect January 1st of 2022. And this, unlike Kansas's rule, does create parity in the way telehealth services are paid in relation to their in-person, face-to-face service counterparts for the same or similar services. There are some new definitions in this Payment Parity Act for Oklahoma. It talks about, it uses a term called mHealth or mobile health. So that's going to be patient medical information, health information. It includes the use of internet and wireless devices by patients to obtain or create specialized health information. It includes online discussion groups, and it includes peer-to-peer support. And that's going to be part of the expanded telehealth coverage in Oklahoma. Defines originating site. Important to note that in Oklahoma, see if I can do a laser pointer here. Oh, look at that. In Oklahoma, the originating site includes but is not restricted to a patient's home. So in Oklahoma, your rules are more flexible on a permanent basis than Medicare, but we still have to be aware of what Medicare's requirements are. Workplace or school are eligible originating sites. It also creates a definition for remote patient monitoring services as part of the Payment Parity Act, and defines that as really the way that these codes are defined in the code set. Their physiologic data, weight, blood pressure, pulse ox, other condition-specific data. And then it defines telemedicine or telehealth, using those terms interchangeably as synchronous, but also would include asynchronous, store and forward. It includes remote patient monitoring. It includes mHealth or mobile telehealth services or other electronic means, kind of a catch-all part of the telehealth definition in Oklahoma. Any health plan that is offered, issued, or renewed after the effective date, January 1st of 2022, must provide coverage of healthcare services provided through telemedicine. And so that's going to incorporate all of those elements. An insurer cannot exclude coverage for a service solely because it is provided via telemedicine. That term telemedicine coming up here encompasses all of those terms. And because it's not provided in person. However, the insurer can limit coverage consistent with coding and clinical standards. But that's it. So if codes are limited in the frequency that they're reported, an insurer can incorporate that same frequency into their coverage limitations under the Telehealth Parity Act in Oklahoma. All right, so here's the payment parity piece of the Payment Parity Act in Oklahoma that was enacted in May, goes into effect next year. The payers have to reimburse the healthcare professional for these services on the same basis, at the same rate that the payer would be responsible for coverage that was delivered in person or absent the telehealth services. Now, these next couple of bullets I thought were really interesting. Someone was clever to put these in there, because it wasn't until I read, when I think of payment parity, I think of the allowable amount, right? That's what we want. Not occurring to me that there may be other creative ways that health plans could discourage the use of telehealth services. And so thinking of those other ways that an insurer could discourage the use of telehealth, this act also prohibits insurers from having separate deductibles, higher coinsurance rates for telehealth services that they would have in place for the same service provided in person or in the absence of telehealth. No higher copay, no different lifetime max benefits that are unique to telemed. So truly trying to put those on par, in parity with their in-person counterparts. No utilization review requirements that are unique to telehealth. If they are already in place for in-person services, they can be extended to telehealth services, but there can't be a difference in utilization review. No restrictions on prescribing medications through telemedicine that are more restrictive than the prescription of medications under existing laws for in-person face-to-face services. And the last piece I think is interesting too, that the payers cannot require use of particular telemed vendors. And I'm not sure how, what the models look like in Oklahoma, but here locally in the Kansas City area, we have payers that are kind of creating their own telehealth kind of department or divisions that their members have access to. And so I thought this bullet was interesting, that I'll pick on Blue Cross, for example. Blue Cross couldn't say, provider ABC, you have to use our telemed service, or maybe you have to use a particular telemed company that the payer may have contracted or negotiated certain rates with. However, whenever you're selecting telemed vendors, or if you're using telemed vendors, they do have to be compliant with HIPAA privacy, security, and all of those other rules and requirements. But the insurer just can't dictate that you use particular vendors. Also can't prohibit you from using certain vendors so long as those privacy and security requirements are met. Oh, sorry, I went backwards instead of forwards. All right, so that's what I have for you in terms of kind of trending legislation topics. I'm going to keep an eye on the Medicaid programs as the state emergency declarations and orders have gone away, to look for any indication that the Medicaid program policies for telehealth are being rolled back. And we'll certainly keep everyone updated on the numerous bills that are out there at the federal level. And hopefully, knock on wood, we get something that will be passed. And if I were to predict the future, it looks like either originating site requirements will be removed entirely, or at a minimum, it looks like the patient's home at some point in the future will be a permanent originating site, eligible originating site for all services. It looks like we're going to have some permanent flexibilities for FQHCs and RHCs. It looks like we may have some expanded availabilities for distant site professionals, and that geographic restrictions have a good chance of being removed from telehealth on a permanent basis as well. So we'll keep an eye on those, and certainly we'll keep everyone posted on changes.
So do we have any questions? I know, as always, Rochelle covered a lot, and it's all very useful and beneficial. But if anybody wants any clarification or has any questions, you can put those in the chat, or please feel free to unmute and ask them yourself.
Hello.
Sure, go ahead.
I'm sorry, this is Chris Bender from Advanced Psychiatric Services. The only thing I'm concerned about, if they enact that 6-month or that initial visit, right now, we're just on the edge of a metropolitan and a rural area. We have patients that are so far into the rural areas, though, that it would be a hardship. I mean, some of them don't even have the money or the available automobile to travel to the office for that first initial or that 6 month, within that 6-month span visit. So, those are a lot of patients in mental health that would just go by the wayside, I guess, if they enact that rule. Is that correct?
Yeah, so that's a great point. The rule for the initiating visit, it's already in effect, but it's limited to a mental or behavioral telehealth visit to a patient at home outside of a geographic area. And I'm glad you pointed this out because I didn't say this earlier, after the public health emergency ends. Because right now, during the public health emergency, we have that flexibility for all services to deliver them to a patient at home outside of a geographic area. So right now, that initiating 6-month visit is not in effect.
Right. But if they put it into effect, I mean, these people are not going to have any care, because some of them don't have means for transportation or reliable transportation to even get to a place to get the help. So that's what I'm concerned about.
Look back on some slides here really quick. Sorry to.
Yeah, that's okay.
What I think that's a really good point, and I think with your perspective being kind of on the edge of the rural area, your patients often are deep into rural areas. It may be helpful for you to, if you click on this this link here, when the slides go out, you can see who proposed the bill and reach out to them. You could reach out to your own congressperson and express support for the Telemental Healthcare Access Act that would take that statutory requirement away so that after the public health emergency ends, that flexibility to be, or I guess that requirement that would then be imposed when the federal public health emergency ends would not affect your patients needing access to those services.
Okay, that would be great. Yes, I will reach out to them because we've also seen with our other patients that we didn't acquire during this COVID and everything is that they all show up for their visits on telemental health, and we've been able to keep them stable, and we haven't had any hospital admissions. I think due to the fact they do show up, they get their medicines, we can make changes if needed. And so I think it goes a long way to also saving our government money by reducing hospitalization. So I will reach out to them. Yes, definitely.
Absolutely.
Thank you for that advice.
That's a great point, and that statistic on access and use of the service and the prevention of more expensive services, I think is fantastic to include in your support for the Telemental Healthcare Access Act. And the other place that would be great to submit those comments, and the deadline is coming up, gosh, it may actually be the 10th, is today the 9th, it may be tomorrow, is the Medicare proposed physician fee schedule. And Christy, I can send you the link to where those comments can be submitted so that in the interim, the requirement to have that in-person non-telehealth visit in the 6 months preceding any mental behavioral telehealth visit, that's something that there is some flexibility on under the statute that Health and Human Services proposed the 6-month requirement, that you may have some insight on these cost savings that you're talking about.
Definitely.
And I don't want to put words in your mouth, but from your provider's perspective, the barriers to access that creates and the benefits that patients and the program would have by not having such maybe a requirement at all, or such a tight requirement.
Right.
Also, one of the comments that I have or plan to submit on that requirement to have 6 months prior to all of the subsequent visits is that the statute requires Health and Human Services impose periodic face-to-face visits after that first one, which could go away if the Telemental Healthcare Access Act gets rid of that initiating visit. Then those subsequent visits, my thought, and maybe this is something that may work for your providers, is that frequency that Congress says Health and Human Services, you need to impose a frequency, could be the provider's professional judgment as needed, right?
So that would be good. Yeah.
Without dictating a bright line requirement that may vary widely and hinder access.
That would be great, because we just don't want the access for these patients, because they've done so well now, because they were able to get care, to go away, and they don't either. So if you send me the link, I'll get that.
Well, I would encourage you to put all of those data points on access and patient benefits, cost savings, and I think that would have a meaningful impact. And professional groups, if you have a state professional group, a national professional group that you can reach out to and make sure that they are submitting comments in support, that's great too.
Okay, sure will. Thank you, and I really appreciate
you're
your
welcome.
webinar. Mhm.
Absolutely.
To anyone that both personal stories, legislators love personal stories, and your legislator especially wants to hear about your personal story in your district. And secondly, yes, you should always look and understand what your state association and your national representative association understands and what their view is, because they often have lobbyists, and they're also people who should be representing your interests. We have one other question that's come in, and it's from Chaka Botley. I hope I said your name correctly. They want to know, what is the best source of providing services, if you are providing services in multiple states, to make sure you're practicing within the telehealth guidelines and restrictions for each state? And that's obviously a difficult problem, but Rochelle, what's your advice?
Yeah, my first thought is the Center for Connected Health Policies website has a great state-by-state guide, and it covers really common topics like establishing the provider-patient relationship, can medications be prescribed, originating site restrictions, and it goes through those different elements state by state. I was just on there earlier this week, and several of the states have been updated even within the last week or two, so their information is pretty current on there. And I think that's at least a good starting point that can refer you to state laws and resources and policy documents.
And I always recommend, when it comes to state laws as well, to reach out to the TRC that cover the Telehealth Resource Center that covers that state.
Yeah, we have resources.
Kansas, Oklahoma,
yes.
Kansas, Oklahoma, and Missouri, but there's a TRC, and if you go to the National Consortium of Telehealth Resource Centers, to their NCTRC website, and we can send out that resource, it will tell you the contact information for the Telehealth Resource Center that covers Nebraska or Iowa or Texas or any state that you may be working with. So absolutely, the CCHP is excellent, but they can't keep up on all 50 states all the time. And so I'd also recommend, if it comes to state law, reach out to the TRC, because we should be knowledgeable and experts. And hopefully not everyone has a Rochelle. We wish they all did, because especially when it comes to Missouri, Kansas, or Oklahoma, we'll make sure to get you good information and correct information about those 3 states.